Hello, everybody. This is Connie Van Egan welcoming you to the Northern New England CTR seminar, Nothing About Us Without Us, Health Communication by and for People with Intellectual Developmental Disabilities. We're here today with three panelists, Kirsten Murphy, Executive Director of the Vermont Developmental Disabilities Council, Nancy Cronin, Executive Director of the Maine Developmental Disabilities Council, and Kirsten Isgro, Project Manager of the Inclusive Healthcare Partnership Project. Um, our second Kirsten, did I get your name right? I'm sorry if I mispronounced it.
I go by Kirsten, just to
Kirsten,
Confusingly,
thank
we,
you.
we pronounce it differently.
Okay, so Kirsten and Kirsten, is that right?
That's right. And
All
then we
right,
have a fourth member with us that was kind of a little, we pulled David Fry in a little bit late, but David, could you just say hello and say who you are?
I'm David Fry. I'm an old uh I work for the DD Council.
Yeah. And you're a leader in the Green Mountain Self Advocates group,
Yep.
and you've been an advocate for many years. So thank you for being here, David.
that's great. I thought I would say a little bit more about our first three panelists, just so you all know a little bit about them. Kristen Murphy is the Executive Director of Vermont Developmental Disabilities Council, an organization that's one of 56 councils nationally created by federal law to engage in systems change activities to improve the lives of people with intellectual and developmental disabilities. She's also the president of the board of directors for the National Association of Councils on Developmental Disabilities, a leader in the disability justice movement. Her 35 plus years career has included leading disability advocacy efforts in both New Hampshire and Vermont. Living in Cabot, Vermont, Kristen is the mother of two adults on the autism spectrum. Nancy Cronin, Executive Director of the Maine Developmental Disabilities Council, has been honored to serve the Council since 2008, working to ensure that individuals with developmental and other disabilities of all ages are fully included, integrated, and involved in their communities and the decisions impacting their lives. Prior to her work in the Council, Nancy served as the Executive Director of the Autism Society of Maine. Her work at the local, state, and national levels has consistently focused on the development of effective services and supports for people with developmental disabilities of all ages and their families for over 20 years. And Kirsten is the project manager for the Inclusive Healthcare Partnership Project, a joint endeavor with the VTDDC and the Green Mountain Self Advocates. She is the parent of a 19-year-old daughter living with a rare and life-threatening condition and has served as a patient and family advocate with a number of local, state, and national organizations. She's currently up.
You've turned
Connie,
mute.
you muted yourself.
I am so sorry. I just went on for 5 minutes to myself. I don't know how I did that. Where did I lose you all? Shall I start over or shall I turn us
I
into
think
the
we're good.
seminar and keep? Okay, I'm so sorry about that. I am not sure I did that, but
We only
uh,
lost we only lost the last like 10 seconds.
oh, really? That's interesting. Okay, well, thank you. And Kristen, go ahead and Kristen, would you go ahead and lead us off and organize this
Yeah,
next step?
sure. Kirsten Isgro's going to put up our slides. Today's presentation is called Nothing About Us Without Us. That is kind of one of the touchstones that in the disability rights movement comes back to all the time. And you heard a little bit about what a DD Council is. We're a federally funded, not an easy thing these days. And really, we mostly work in the policy space and sort of traditional advocacy. But today, we want to talk with you about another one type of strategy we use, which is pioneering best practices. And I've had the pleasure of knowing Nancy, my colleague from Maine, for a long time. We had been in Vermont, been doing some work around healthcare issues, and I knew that Nancy had also done that. And so it just seemed like a great opportunity to collaborate. If we could go to the next slide. The Inclusive Healthcare Partnership Project has really been around for quite a while now, maybe a decade. It's had different phases. Initially, it started with a white paper that in Vermont we published almost a decade ago about the root causes of health disparities for the IDD population, based on qualitative data. That is, frankly, just the stories that people with lived experience, adults with developmental disabilities, shared with us. And this was long enough ago that there was not a lot of recognition, formally, especially by federal entities, that developmental disability and disability in general is a health disparity population. So we were excited to sort of be raising that up in Vermont. We were able then to get a small CDC grant to do some actual um, data analysis based on the BREFIS data set that showed how much Vermont was impacted by this health disparity. And then we were very excited to get another CDC grant through the Department of Health in Vermont to really lean into how healthcare information can be made easy to understand for patients with IDD. And as a sort of second piece of that project, how doctors, nurses, and other healthcare workers can increase skill in communicating with our population. Nancy, if you want to give a tiny thumbprint of what Maine has been doing in the healthcare space, and then you're going to set the table for us with some data about why we're talking about this.
So I'm really happy to. Maine took a slightly different approach than Vermont, and we started working with our federally qualified health centers and our Maine Primary Care Association in trying to talk about how do you increase doctor and medical professional capacity of providing care to individuals with developmental disabilities. And we knew that a lot of folks were not getting a lot of great care. And I'm going to explain a little bit more about that in a little while with some work we did with ECRI and patient safety organizations. But the bottom line is we realized that the best thing to do was to join together. And because people with developmental disabilities are our patients in the community, the best way to provide training to doctors is wherever they're getting training. So we tagged on to an echo series. And when people talked about blood work, there was a little bit of didactic in which we talked about how do you ensure that we're having appropriate blood work for people with developmental disability. When you are increasing your capacity about diabetes, we just included that as a segment of the population that people were learning about. So it was not special care. It was embedded in care that people provide. And what ended up happening, and I'll share later, is some pretty cool patient readiness work that we were able to do that eventually became a promising practice with AHRQ. Later, we worked with PCORI and got a grant to how do we include people with developmental disabilities, researchers and doctors, to really know what is research that matters so that when we're spending time with research, we are asking the right questions to move the needle. Next slide. And the reason we did this is some pretty compelling data. There's a lot of research that has come out in the last 10 years, largely about gaps. So very little about how do we move the needles of improvement of care. So that is a real issue. But what we know, and I found these particular studies compelling, is that if you look at people within the with developmental disabilities in the United States who have no comorbidities, and you compare that to people who do not have developmental disabilities, nor they don't have any comorbidities, people with DD still die 10 to 15 years earlier. Next slide. The next study we started really looking at was, this isn't a phenomena just for the United States of America. There was a similar study that had come out in 2014. The United States of America was 2020, that found that people died 13 to 20 years. Next slide. And then the research started looking at why. And finally, we had enough data in which there was a study of a meta-analysis that looked at 63 high-quality studies and really found 6 consistent barriers to good health. Next slide. The first is healthcare providers need training. The truth is in many parts of the country, including Maine, in Maine, our institution closed in 1996, and people moved into the community, and we asked doctors to care for us. The problem is we didn't actually prepare the community healthcare field. Another problem is we didn't actually prepare individuals with developmental disabilities to heal from the trauma that they had within the institution. So there was this massive mismatch of information. Part of that is healthcare providers need training. There's a lack of specialty in training in this field, and part of that is a challenge, and part of that is okay. We do not want to create a system in which, because you have Down syndrome and you have a sore throat, you have to go to a specialist. It is important to recognize that people with developmental disabilities live in our communities. Therefore, they need to be treated in our communities' health centers. But it is impossible that doctors are going to be able to know every single thing about people with developmental disabilities. The needs are too vast. And frankly, within the last 20 years, people are living significantly longer. So we have a real problem around providing the right kind of training when they need it. The next section that this meta-analysis found is healthcare providers need better access of how to accommodate individuals with developmental disabilities so they can be successful in safe healthcare, well visits, general care, as well as hospital care. So there's that. How do you change the environment to be suitable that people are more likely to be successful? Another area which is extreme and on both sides of the coin of patient as well as medical provider is there is a real need for plain language healthcare information, and there's simply it's inadequate out there right now. And inadequate communication can result in the wrong diagnosis, inappropriate medication, and can really prevent a person's access to adequate health care. Now, patients often find healthcare situations very stressful, and that can impact the ability to do poor communication. It can generally lower expectations of what an individual's ability is. Frankly, it can seriously increase no-shows, and that's a real problem for both the person who's not getting their appointment and the practice that had the slot. And many people with developmental disabilities have ineffective healthcare. So one of the last challenge around communication barriers is we must have a good, trusting relationship is vital to caring for these patients. Seeing the same healthcare professionals is important, but that can be a real systemic systemic barrier in today's system. Next slide. Oh no, I lied. Back. I'm sorry. I have my notes on a different slide, and I need to progress to my next slide. So I apologize. So, all right. Individuals with IDD may be fearful and embarrassed. I know that may sound odd, but in Maine, for instance, there are many individuals who lived in the group home in Pineland, which was our institution, and they don't have teeth. And the reason they don't have teeth is because people who called themselves doctors pulled them out because they were biting wrists. Or there was a feeling in the 60s and 70s that people with developmental disabilities might not feel pain in the same way. And the individuals who lived in Pineland are now the patients of today. They're just our elderly patients of today. But many of these individuals are really afraid of going to the doctor. Another section is there's a lack of involvement in healthcare decision-making. People talk to the person who's with them, which may know them and may not know them. Frankly, there's shared decision-making is a tool in the healthcare community, but it's also a different tool in the disability community. And we would love to see how do we kind of model so that shared decision making between caregiver, individual with a disability, and doctor may work better. And the last real barrier is time. Everything takes longer. Next slide. And that's mine.
Thank you, Nancy. Um, so ex one of the things I find exciting about that last slide with the various drivers that the meta-analysis identified is that it did come several years after our, frankly, far less sophisticated white paper about health disparities in Vermont for this population. But in fact, the factors we identified by listening to the stories of patients, adult patients with IDD, we came up with many of the identical key drivers, especially around the communication piece. So I just to zoom out a little and kind of again have a policy look at this. It wasn't until 2023, so into the Biden administration, that a large federal agency finally recognized that people with disabilities in general, and IDD in particular, were a health disparity population. So think about that. It's one of the largest health disparity populations, and is one of the very last to be recognized by sort of the public health drivers of, in the United States. In fact, HRSA has yet to recognize disability as a health disparity population. And then, of course, very sadly, tragically, we've had some setbacks in the policy arena in how we are speaking about people with developmental disabilities. As the mother of two adults with autism, I can't say how misguided and frankly dangerous this kind of ableist speaking and public facing comments are. Next slide. Why is that? Because provider attitudes are so important, Nat. And I share this not to judge, but rather to say that we need to better support our providers to do this work. This is a study I rely on a lot. It's from 2021, not that long ago. It was a survey of 714 physicians, a combination of primary and specialty care. Only about 41% said they reported feeling very confident about their ability to provide care to people with disabilities and to provide the same level of care as their other patients. A little more than half said they strongly agreed that they welcomed patients with disabilities into their practice. So imagine if you ask that question about people from any other health disparity population. For example, do you welcome patients who live in public housing into your practice? And you got this result, I think we would find that pretty troubling. And then there's a lot to unpack in this last piece, but 82%, a little more than 82%, said people with disabilities have a lower quality of life. If that is an assumption you come to the table with, that's pretty concerning. And I know that my son and daughter would not say that they have a lower quality of life. Um, Next slide. I think it's time for us to bring David into the conversation here. So I hope you like. I hope those pictures are a good surprise, David. I've had the opportunity to travel with David to a lot of different conferences. So that's a picture of David. We ran into, of course, this happens a lot. We ran into Senator Sanders while we were flying to. I forget where we were going. Maybe that was when we went down to Louisiana. The middle slide is a different conference. David is being inducted into the leadership circle of our national association. And then a picture of David here at one of the highlights of the year in Vermont, the Voices and Choices Conference, providing some outreach to the LGBTQIA population in our state. So I think Kirsten Isgro, you're going to kind of do a little
Yeah,
bit of this dialogue. Thank you.
absolutely. David, it's so nice to see you. I heard you just moved to Burlington.
Yeah.
That's cool. That's very nice. Do you want to talk a little bit about that, just in terms of what it took for you to advocate to get your own house here in Burlington?
Uh,
'Cause
well,
that's been a
I
long
was
project.
I was paying a lot of money where I was living, and it wasn't really saving me, and it was taking all of my SSD money to live in the old place, and plus I had to pay for my own heat.
Yeah.
So I was like struggling, and they knew that I was struggling, so they said, you need to be on Burlington Housing, and
Nice.
so they got my
Great.
name involved in that, and then this place popped up. So
Awesome. Do you want to talk a little bit about our focus groups that we did with the Inclusive Healthcare Partnership Project? Because you were involved with those for the 3 years that we've been working on this project. Like what we talked about, how they went, and what kind of contribution you made, because you were really important to this process.
yeah, so they would bring the information to the table, and they would draft the booklets, but really they never really heard stories from intellectual people with disabilities about what we face when we go to the doctors. And like, some of the things that come up with me is, uh when a procedure's getting done, what does that detail in? um or if there's a medication that I don't know anything about, I want to know what the side effects of that medication are.
Mhm.
Um, uh, and so things like that. I think, during COVID, I don't think people knew how to deal with COVID, and what were what should we be looking out for, and what is the next steps when you do get COVID,
Right.
and
And the Green
and
Mountain Self Advocates, do you want to talk a little bit? Because you've been involved with the Green Mountain Self Advocates for a really long time, and some of the people that are here today may not know what that means to be a self advocate, particularly in the disability community.
yeah.
Do you want to talk a little bit about that?
So Green Mountain Self Advocates was established after the institution closed here in Vermont, and we have like 24 different groups throughout the state of Vermont or something like that. I'm not really sure, taking a guess. And so they come out with booklets all the time, how to uh they came out with a booklet about COVID, what you do when you get COVID. um you need to get a shot, and it was really, really in plain language, which
Mhm.
a lot of the stuff that we we get, and the stuff that Green Mountain South Advocates do, is we break things down into plain language, because that is so important in our world. Is to have things in plain language.
Mhm.
So, I belong to this group, and um I think I bring good things to the table, and I like to think, when decisions are being made for us, we need to be part of the table.
Yeah, yeah. And I think
Yeah.
that the idea of self advocates, and you embody that, is what are your needs and what do you need from your healthcare providers as well as housing, and
Right.
being able to speak about that and also have support in doing that, that advocacy. So that's really great. Do you want to talk a little bit about a couple of your health journeys that have helped inform what we're doing with this project? Like some of the things, so I know you have some chronic pain in your leg, and we had talked the last time about doing some of the weight loss medications and what that experience has been like with your doctor.
Well, the pain thing that I have is, I'm on my feet constantly in food service, so I tend to have leg pain, and you know leg problems, and so I brought that to my doctor, and he basically said that I need to be on like a aspirin, regimen every day. And then I started to get diarrhea, and they said, well, it could be because you're on that kind of medicine. So I stopped taking it, which I have a doctor's appointment this coming Monday to
Mhm.
go over with all about my meds because
Mhm.
something is not adding up.
Yeah, so
Then
yeah, go ahead. Sorry.
then the weight loss program, I was on Ozempic,
Hmm.
and that was giving me diarrhea. I mean, severe diarrhea. And I told the doctor, I said, I didn't want to be sick all summer long with
Right.
diarrhea. So I just said I stopped taking it.
Yep. And what do you like about the your doctor that you have in terms of
Well,
working together?
he's a new doctor, and I've only seen him once or twice. So his name's Benjamin Baker at the community health center here in Burlington on Riverside Ave.
Mhm.
He's real. I like him.
Mhm.
Um and I'm going to give him a chance that I'm going to like him. And so I see him again on Monday, and I'm gonna go over with all the meds that I'm taking and uh go from there.
And he takes time with you to the point that Nancy brought up. Like he you don't feel too rushed when you're meeting with him.
No, not at all.
Yeah, that's great. Thank you, David. Yeah, I want you to stick around because I'm sure there's going to be some questions. I think Kirsty and Nancy wanted to talk a little bit more about some of the other projects that their DD councils in Vermont and Maine have been doing. So
Cool.
Yeah.
yeah.
Thank you, David. Appreciate you. So I'm going to talk a little bit about a piece of the path forward in inclusive healthcare. Next slide. So, the goals of the Inclusive Healthcare Partnership Project are to create plain language health information by and for, and let me stress by and for people with developmental disabilities. And we've also had a second goal around helping nurses and doctors and other providers communicate effectively. But today, I really want to focus on that plain language and what we mean a little bit more about that. So, plain language has some, some standing now in the law. The Plain Writing Act of 2010 requires federal agencies to use clear communication that the public can understand. And we at the Inclusive Healthcare Partnership Project decided to interpret plain language for the purposes of our health information as no higher than fourth grade. And there are now computer programs that can calculate all of that for you. Here's some just a quick, we have a longer checklist on our website, but here's some things to know about plain language. You put the most important information first. Many years ago, I was a journalist. That's also what you do when you're writing what used to be called a newspaper article. Um, but here's the other thing, though, that's really critical. Focus on need to know information, not nice to know information. I think a lot of facts are interesting and nice, but what I need to understand from self advocates is what do they need to know? So some of you may know that we had terrible flooding twice in Montpelier and central Vermont, the capital. Um, and all of a sudden, all these flyers showed up in all the public housing and, telling people there's a boil water notice. Well, so we asked self-advocates, do you know what to do if it says boil water notice? And nobody did. Like nobody understood what that meant. And what is that like? Do I have to boil the water that I brush my teeth with? Can I take a shower? Um, can I, if my garden was flooded, can I eat the produce that was in my garden? There were a lot of things that we learned from talking to people in a focus group setting that alerted us to what the public health message needed to be for our population. And there are other things that, we might think are nice to know, but they're really extraneous. The other example I often use is that one of our lead staff members at Green Mountain Self Advocate, just during the COVID public health emergency, he's a birder, and he takes a lot of pleasure in spending time outdoors. And the messaging that came from the state of Vermont was stay safe, stay inside. And he like thought that meant like he couldn't go out for a walk. He thought, he didn't understand. There was a nuance to that didn't make sense. So again, I wouldn't have intuited that. I needed to ask self-advocates what they were understanding. So these are so some other, quick short sentences, smaller vocabulary, all of that. But do if you there are good checklists out there now. The other component we added, and this is like the most fun part of the project we did, is we had a professional cartoonist who provided the visual supports for each of our healthcare booklets. And I think there are 14 of them now. Some talk about things like patient rights and advanced directives. Others talk about specific types of disease management. We tried to really lean into diverse images as well so that people could really feel that they were seeing themselves in the cartoons and not feel anxiety or shame about body image or we really tried to avoid things that were triggering. Every single booklet was workshopped, focus grouped 3 separate times at least with groups of about 6 to 8 self-advocates so that we were iteratively checking, are we getting the messaging right? Have we provided information that you find you needed to know was valuable to you? Did we miss something? How does this image make you feel? Last one.
I
Last
also
next slide,
can I jump in real quick also?
please.
I think, David, this is where you and your self-advocate Green Mountain crew were really helpful because you actually came up with a lot of the ideas of what kind of images Teppy would draw. So I just want to
Right,
thank you for
right.
that.
Yeah, that's absolutely true. And this is just a sampling of the booklets we have on our website. They are printable. There's an order form where you can get them from us in physical copy, not that people do that very often. And then we have created voiced over videos with the same artwork and with voices of people with developmental disabilities sharing the information auditorily so it's accessible for people for whom that's an easier way to learn. I think I kick it back to you now, Nancy.
You. And so Maine has similar issues regarding healthcare and healthcare access. But the fact is Green Mountain at Self Advocates and the work that's happening in Vermont around plain language is simply outstanding. So there's no need for me and Maine to recreate that work. So we looked at things from a slightly different point of view, and we targeted 2 additional pieces to improve access for quality healthcare. The first thing we did is we understood that for doctors to understand that they need to maybe learn a little bit more, make a little bit more room for people with developmental disabilities, is we needed to understand what are the issues. So we worked with ECRI, which is a patient safety organization and Maine Primary Care Federation, and we did a large study based on insurance data and Medicaid claims in Maine. And we were able to document that there is lower utilization of general primary care. And we were able to find chronic issues treated in the emergency room, high usage of emergency room and urgent care, more likely to be hospitalized for conditions which should be managed in outpatient. And there was a lot fewer screenings than average. Next slide. We also looked at what kind of patient safety issues did people with developmental disabilities specifically find? And we found in Maine that there were 777 events that qualified specifically for what we were looking at. 250 events. Then we dove in because they were in the ambulatory setting. That's the doctor's office, and we started looking at what they were. And the results of these incidents were fascinating. They were told from the staff perspective, and to me, they were exactly how you are taught to document. Patients stood up, ran out of office. a patient swung and hit somebody. Patient swore loudly, and it seemed significantly, well, it seemed a little scary, frankly. And when I looked at it, I looked at each one of these things and I said, oh my gosh, each one of these incidents is about an individual who is afraid and has no access. They have no way of being able to engage in a personal level. And you know, when we all sat down together, I said, you know, this told from the staff perspective, in some ways, the way we document things could actually be potentially even increasing fear and bias from both sides. It's just not cool. Next slide. So we really started to engage Maine Primary Care Association and our kind of equivalent to Green Mountain Self-Advocates called SUFU, Speaking Up for Us. We worked together to create a primer, a care readiness assessment tool that gave no cost, low cost tools to practices to be able to provide better care. And we wanted to know, will this decrease those events? You know, things like, how do you schedule? How do you set up the office exam room? How might you communicate in different ways? How do you staff prepare? Just really low cost, no cost. And then we brought that and we ended up having it tested. I don't remember exactly where, I'm thinking Chicago, but they ended up testing this in a place outside of Maine and found it as a promising practice. Next slide. So it did increase, and we were honored to by the Agency for Healthcare Research and Quality to have this as a impact case study. So it was really, really exciting. So we worked to get that out, but it wasn't enough. Next slide. You were absolutely right. What I said before, in the research tends to say, here's the gap. But nothing says, how are we going to improve the gap? How are we going to move the needle? And, you know, Maine Developmental Disabilities Council applied to PCORI for an engagement grant to learn about research. How do we create a research team that includes people with developmental disabilities, families of people with developmental disabilities, doctors, researchers, advocates, and direct providers? And we learned together about patient-centered research, comparative effective trials. We learned how to be a part of a research team from kind of the beginning to end. And we never got an opportunity to use what we learned, but what really we learned was including individuals with developmental disabilities in the room isn't enough. So what we need to do is create almost dynamic new norms. Let me give an example. We had all these individuals with all these different lived experiences from different points of view in the room. And one individual was very excited about going on a trip. And the screen was on, and it was very distracting. And we had a conversation about how nobody had ever said, if you're going to be distracting, shut your camera off. You know, these are kind of hidden rules. But and some of the doctors and the researchers were uncomfortable saying those hidden rules. And the self-advocates were like, well, how are we going to engage if you know things that we don't? You know, we need to have group norms. We need to figure this out. So we developed shared leadership in which we really created norms. The next problem is we started talking about our stories. So people with developmental disabilities and their families talked about their experiences, while kind of doctors and researchers reacted to those experiences. And that created a power difference. And we realized this isn't going to work. We need to get on the same place in which we're all kind of starting from a shared story narrative. And then how do we learn themes so we're at it the same way together? And it was magical. The people who had the most trouble with this was the doctors, oftentimes, because they're not used to telling their stories. But once we get to a point in which everybody was telling the stories and seeing joint themes, we created a different level of belonging. And it changed the conversation in a very different way, in which we could really start looking at why are these health problems happening, and really looking at decisions that problem points, decision points that matter to literally everybody. So we developed these principles of engagement. Next slide. So it also was very well received, and this was provided and chosen to be highlighted at PCORI's annual meeting. We're proud of the work. Next slide. So here we are, and Kirsten talked to me about this, and she said, how do we know that these materials are effective? You know, we think they are. We know plain language is a problem. We know communication is a problem, but how do we know? And that was when she and I kind of put our heads together and said, you've got a tool that needs testing. And I've got research teams that has created this new way of doing research where it truly is. And it truly is a dynamic way to get research done where all voices matter. And that's kind of the next step. How do we know what is the most effective way to communicate in plain language? And can we do it where it's not experts doing the research, but all of us with shared living? And when I say all of us, I mean doctors and that point of view, practice staff. Everybody has a shared point of view that's different, but you need the patient, or I'm sorry, they're not patients, the individuals with lived experience, the researchers with lived experience, to be able to see obvious things. So I really, really appreciate you letting me speak, and I'm going to turn this back over to my colleagues.
So I do want to make sure that we have some time to have some conversation. And David, if you have anything else that you want to add, I also I appreciate, Sheila, for you inviting us to share all these activities that are going on, because I think aside from what's happening on a federal level, you know, we work in our tiny little microcosm and create these great projects, and then it's like, okay, what's the next step? And so one of the hopes is that we will apply for a pilot project with the Northern New England Clinical and Translational Research Network. And we could do a couple of things, right? One is continue the work, as Nancy just talked about, really developing some solid research and continuing looking at how do we help clinicians be better and have better skills in terms of dealing with patients that do have developmental disabilities. I think the other piece that with the Inclusive Healthcare Partnership Project, we got funding to create the materials, but we didn't have a next step funded in terms of looking at pre and post surveys of how the materials that David has helped us create that, you know, address vaccines and COVID and dental care. So I think there's a lot of need in terms of looking at what the impact is and what the health outcomes are when our self-advocates and people with IDDs look at this material and use these materials and maybe take them to the healthcare setting. So part of it, and Sheila, you can jump in here, is, you know, kind of a plea to try to think about what are some creative ways that we could work collaboratively to make sure that these projects move forward. And I think now's a great time for us to have some conversation.
And I think we need to do more booklets on other things as well.
Yeah, like what kind of topics, David, do you think we need to?
Well, I was in a car accident a couple, year and a half ago, and I maybe this isn't even a medical thing, but like, how does a person with disabilities, um, how do they stay calm?
Right.
And what are the steps that need to be done when you're in a car accident?
Right.
Yeah,
Right. Yeah. Yeah.
that's a great
Because I'm
suggestion,
like,
David.
I was like
That's
froze when I was in a car accident, and thank God there was a cop coming
um,
towards my direction, and he stopped and he said, "This wasn't your fault. There was a guy in back of you."
Hmm.
And then he went the other direction to chase him down.
Yeah. Yeah.
Wow.
Yeah.
David, I think that that's a really good suggestion. And another way, some of the people that we looked at is fear of getting shots. And how do you work when you're afraid and fearful of what do you do when there's kind of a trauma and you're in the middle of it right then and there? Those are really, really important topics.
And David, if I can, just kind of jump in, we do have, if you remember, because of when you were telling your story about your car accident, and then I think we started making it a little bit bigger where we were looking at safety if you had an accident or if you had a fire. And so we do have a public safety brochure that we created out of your experience, but it wasn't specific to car accidents. Yeah, I see a hand. Connie?
Connie.
Yes. Thank you. I think you can hear me right this time, right? Yes,
Yes.
yes. Everybody's thumbs up. David, you said something that I didn't quite pick up on. You said, I think this is time for it, or there's a time for book clips. Did I hear that right?
Book,
I,
book
I
club.
think David said we need more booklets, and we had made about
Booklets.
14
God,
topics. Yeah,
dang.
yeah.
So is
And we have 14 topics. We had many more we wanted to do. Vermont, for example, has very high skin cancer rates. And I really want to do, people often will sort of say, oh, well, why would I bother to have so and so put on sunblock? They have disabilities. Their life is so difficult. Yeah, exactly. Thank you, Sheila. Their life is so difficult. Well, we're not going to pile on another thing. Well, probably they said wear sunblock because they have skin. Okay. So it's just the rules aren't different. So but also we want to empower self-advocates to know, hey, where's my sunblock? Or if I'm going to go be in the water, go to the beach, I should probably put this on. So I think that there are just myriad topics we could tackle.
Yeah.
Jackie.
Yeah, I see. I just want to jump in, Jackie,
Yeah.
before we take your question. I think some of the other wish list in including the car accident, David, that you talked about. We also talked about, in addition to skincare, sexuality and mental health,
Yeah.
and those were just so big. And we also found that there are some other agencies and states that are taking on those topics. That's not to say that we shouldn't, but yeah. So Jackie, and then I also see Alex, your hand.
Sure. Hi, everyone. My name is Jackie Feiss, and I work at the Center on Disability and Community Inclusion, and I'm an educational consultant. Hi, guys.
Hi.
And I'm in a unique spot because I'm an educational consultant, but I also have developed 5 chronic conditions, and many of my students that I support are developing similar things, like long COVID, for example. And I'm finding in my work during the day that I'm creating a lot of materials that are around healthcare needs. I also joined the LEND program this year because I'm really interested in like bridging these two worlds that I live in. And the thing that I would really love support with, or I wonder if it already exists, is like a visual of pain, different types of pain that you're experiencing, different symptoms that you are experiencing that could maybe live at doctor's offices, or we could co-create this material together so that people have that visual when they're in the office to be able to describe what they're feeling. And I wondered if that's something that you guys have considered, or if you're ever looking for a partner. I'm working sort of in isolation over here, and I would love people with more expertise than me.
Maine did a project for that. So we ended up doing When Behaviors Change, Check Pain. And we did a deep dive on pain charts and what evidence-based material is out there. Canada has actually done a lot of it. And if you email me, we have our results and I will send them to you. I'll drop it in the chat. We hired a nurse and tested a number of different materials, but they're from the doctor's side in the hospital. You know, I've really stayed very much away from plain language because we have experts in Vermont. But if you email me, there you go.
And Jackie, we did create a booklet on long COVID. Of course, that's a little bit of a moving target as the research evolves. Um, and I can't remember if it was in that booklet. I think it was.
I'm trying to pull it up. I'm trying
I
to pull
know
it up,
we did
Michelle.
some work on body mapping and sort of we ended up with a visual that it's a little different than what you're talking about, but we did sort of a map of what the symptoms and where they might occur. Yeah, there we go. Thank you, Kirsten. You're fast. Um, I mean, all of this could be expanded and, worked into other tools as well. So yes, I would be happy to talk further with you as well. Um, Alex?
You.
Hi, good afternoon, everyone. My name is Alex Gilman. I'm the Senior Health Programs Manager for Special Olympics Vermont. My background's in nursing. I just completed a master's in nursing education, but I just want to thank you all for having this conversation, and just want to throw it out there that a lot of the work that Special Olympics is doing across the state, we also have health programming where we're trying to, it seems like, accomplish the same tasks with a lot of the same resources and like the same way to accomplish that. For example, addressing like lack of healthcare training, professional and student training. In Vermont, we've developed online like professional training that individuals could take. We go out to students and healthcare professionals and do trainings. So like would love to partner or just work with you guys more on that. Like in the presentations, I tell them about the plain language checklist that you guys have through the Inclusive Healthcare Partnership Project. I literally, if I could turn my computer around, I have it right above my desk, so I use it every day.
Oh, that makes me so happy,
Yeah,
Alex.
yeah. So like I'm sharing all your resources out as well.
Thank you.
We also, I know a big part of it is kind of the implicit bias that healthcare professionals tend to have, or that, and Special Olympics worked with the Harvard Project Implicit and created one for individuals with IDD. So that's something that I share out as well, and would be, if that's useful, could be useful for you. Nancy, I have a colleague in Maine who her name is Grace. She's fantastic. I could connect you both. She's would be a great resource. I'm sure would love to hop on and help with a lot of the projects that you were talking about.
That would
And
be
then
great.
I'm also working with the UVM College of Medicine. I saw Dr. Carney was on here, I believe. But yeah, so like we've done projects essentially. It sounds like I didn't know of the projects that you've already done in the research, but we did one last year that essentially found that people with IDD experience generally good healthcare experiences, but a major barrier is that communication piece that I think we've kind of all know about. So now we're kind of diving into that piece and doing more research on working with doing interviews on how communication could be better enhanced, and then hopefully updating our trainings and all that. And then we have our health messengers, which I'm sure you guys they overlap a lot with the Green Mountain Self Advocates. So I'm sure you are familiar with a lot of our athletes in general. So essentially, long story short, we would love to talk more and partner and kind of make sure that we're working together and not doing stuff siloed, essentially.
Yeah, I would love that. I have so much respect for Special Olympics, which just sort of reinvented itself. I don't know exactly when, maybe in the last not quite a decade, as this like incredible force for public health around these issues. So yeah, we would love to partner more with you.
Awesome. Thanks.
Other questions, reflections?
I
Oh,
know
yes, County.
Thanks. I know we're running out of time, but I would be fascinated to know more about the plan for the pilot project, the sort of your next step of how to help clinicians improve. You've talked a little bit about how you developed in the PCORI Engagement Award, a way of creating new norms and sharing storytelling and principles of engagement. But I know that carrying that into the clinical realm is another step. And it and when you mention that adults with IDD are fearful and embarrassed, I suspect that clinicians can feel afraid as well to not mess it up, not do it wrong, not to get to feeling comfortable so that they're doing the best they can and being the best care providers they can for every population, but including adults with IDD. So it would be great to hear more about that sometime, but I doubt that the next few minutes really provides that opportunity. But I really appreciated this. Thank you so much.
Thank you. We
I'd
really
love
are
to
looking
talk.
for some clinical partners, that can, because we're trying to figure out what our application should look like, and we're trying to figure out who would team with us as, as a kind of clinical from the clinical side. So yes,
Well,
Sheila.
and if I can insert a little bit of information there, there's a very short turnaround time for the letter of intent for the pilot projects. They're due December 1st. But I think this could go in a number of different directions. One of the key things is you do have to have UVM or Maine Health or both collaborators.
Yeah.
And so that's the key. But you have a few people right here on this call that would be interested in potentially working with you on that. So between that and the great work you've already done, I think you've got the potential for a solid pilot project. I can help connect people if you don't have each other's emails, and set up your meetings and stuff like that. And we also have with Dr. Carney, she has rural communication navigators who specialize in community engagement and outreach and bilateral conversations. And they're available to help you design and develop your pilots as well. So we have a lot of resources at the CTR that are ready and waiting to help you. We just have to flesh out an idea and see how we can make it work.
Right.
Yeah.
Exactly.
Thank you. And thank you for this opportunity to talk about our work today. Really
Oh, it's such
appreciate it.
good stuff. It's so good. I'm so fascinated. I have a million questions like the storytelling thing you were doing up in Maine. How did you collect those stories? What was the mechanism? I mean, it's just phenomenal. So, I'd actually like you to do an article for our newsletter soon and embellish on some of that and so that we can give more information out to our readership.
I'd love it. That'd be great.
It'd be awesome. Thank you so much.
You're very welcome.
Thank you. Thank you, David.
Thank you all.
Okay.
Enjoy the
I'll
rest
have
of
the
your day.
recording linked on our website within a couple of days. Okay. And I'll send you the links.
Great.
Fantastic.
Thank you.
Thank you very
Thank
much.
you.
This was wonderful.
Thanks. And Sheila, I'll be in touch.
Okay. Bye.
Thanks.
Bye-bye.